So this webinar is being recorded just as a FYI. So welcome everybody to the July webinar for the Wisconsin DOJ summer webinar series. Just a couple of housekeeping details about the webinar. So you will notice there is a chat feature. So feel free to use that to introduce yourself if you'd like and say where you're from and where you're practicing. As far as any questions that come up during the presentation that you have on the content, you can chat in the Q&A feature that's down below. That just helps me keep track of the questions and that they get addressed. You can also use the raise hand feature so I can unmute you. Everybody is automatically muted on this, but sometimes it's easier to have a discussion. So please feel free to use that feature and then I will go ahead and unmute you and then we can have a discussion about that. As I mentioned, this is being recorded and will be available for viewing probably 2 to 3 weeks afterwards, and it should be posted on the DOJ SANE website. There will also be an evaluation sent to you through Qualtrics, which we would appreciate your feedback on. This helps us know what other things we can do as far as continuing education or any improvements we can make or any suggestions for future topics. So with that, we have Kara back with us again from last month. Everyone absolutely loved her presentation. So she's a hot item. So she's back again. So I will turn it over once again to her and I hope you enjoy this class. I'm really looking forward to it myself. So I hope it meets all of your needs. So go ahead, Kara.
Awesome. Thank you so much for having me back. I'm so happy to be with you again. For anyone who I didn't meet last time, I'll just do a really quick introduction. My name is Kara Berg-Ronick. I am coming to you as the Director of Clinical Quality for Healthcare Education and Training, a nonprofit that focuses on sexual and reproductive health outcomes, improving sexual and reproductive health outcomes throughout the Midwest. I am a nurse practitioner with a background in reproductive health and family planning. So that's kind of where pelvic care is very much central to my world and the clinical care that I provide. And I'm also a certified SANE. I practiced as a SANE at the Cleveland Clinic for several years before moving back to Indiana. And there we did full scope forensics, so mostly sexual assault, some domestic violence, elder abuse and neglect, child abuse and neglect. I always share, I took care of a dog bite on Thanksgiving. You all know the scope and breadth of the amazing things that forensic nurses do. What else? As far as trauma, my doctoral research, I have a doctorate of nursing practice, and my doctoral research focused on vicarious trauma among SANEs, which we will touch on briefly today and could kind of be its own whole thing at some point. No pressure, Susie, but that would be fun too. So I really started diving into what trauma-informed care and what a trauma-informed approach to all that we do looks like at that time, and I've continued to kind of incorporate that into my practice, whether it's been forensic or as a nurse practitioner or as a colleague and human moving through the world. So that's kind of where we're going to go today. As people who were with us last time may remember, I really I'm so sad about the virtual format. Of course, being in Indiana, I'm in Indianapolis, by the way. I'm grateful that I'm able to be here with you like this, but please feel free to unmute or to throw things in the chat, be communicative. I'll throw a couple questions your way and ask you to give me some thoughts in the chat, and we'll go from there. So here we go. Trauma-informed pelvic care for the SANE. We're going to hope the slides advance. There we go. Okay. No conflicts of interest. This is a little bit about HCET, which I already sort of mentioned, but really great organization, and happy to answer any questions about that later as well. Okay, so where are we going to go today? We're going to define trauma-informed care. We are going to discuss the pelvic exam through a trauma-informed lens. And then we're going to break that down even further to talk about strategies for using a trauma-informed approach while providing SANE care. So you craft objectives before you develop the presentation, right? If I were doing it again in the wrong way, I would add something else around just defining trauma, because we are going to spend the first chunk of today's presentation just establishing sort of a shared language around and understanding around what trauma is. And I know that there are pieces of today that feel funny because y'all as SANEs are the experts in this. And so I'm super open to feedback if some of this is too 101, but hopefully it'll be kind of a good perspective, maybe review, and hopefully going deeper than you've had the opportunity to go before in some areas. So we'll go ahead and kick off with trauma. And the definition that I like to work from is from SAMHSA, the Substance Abuse and Mental Health Services. And so here it is. Individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. There are a million definitions of trauma. The DSM has, crafted and changed theirs. And in fact, in the DSM-5, one of the things that they did is actually make it a more narrow definition, which has some reasonable rationale, perhaps for the DSM. But I think that when we are working in the context we're working in the way that I would like us to think, especially as we approach a trauma-informed approach to care, this broader definition makes a lot more sense. So a couple of things to keep in mind. Exposure to trauma can be direct and personal. It can be about you. It can also be about witnessing trauma to others, or indirect exposure through traumatic experience of a loved one or family member. So again, we're talking about self and loved one. It also can be actual or perceived. Experience is key. That's one of the big takeaways. How a person experiences something determines if it's traumatic or not. So something traumatic for one person may not be a trauma for another. So I think one example would be like siblings that are removed from an abusive home may have a very different effect on one sibling versus another. For one, it may be a healing and a good thing, not, of course, complex and not ideal to be removed from the home, period. But for another, even though it's being removed from an abusive situation, that removal can be intensely traumatic, right? Think about all kinds of scenarios where one person's experience does not fit all. The effects can be immediate or delayed. They can be short-term, long-term. So basically, a lot of personalization here. And I think that is sort of a good foundation. Again, feel free to throw questions in. So we're going to break down some of these components a little bit more. So you'll notice in that definition, it talked about events. So this is sort of the events or categories of trauma. And I think we can think about them in the following ways. And while we're doing this, if you want to throw some examples up, that would be awesome, just to get a break from hearing me talk. So acute trauma, I think, is often what we think about first, right? A single or short-term event. Can anyone come up with some examples of what an acute trauma might be? Toss something in the chat for me. This is also your cue to be thinking about the others. As SANEs, y'all have a pretty good example. Yeah, sexual assault is a perfect example of an acute trauma. Anyone else have any thoughts? Thanks, Jill, for being brave and jumping in there. So something like a car accident would be an acute trauma, right? Okay, racism will fall in a different category, although there certainly could be an acute hate crime incident. And so actually that's a great place to start with, where these can, of course, nothing is as academically perfect as these categories. A sudden unexpected loss, right? Witnessing a death, absolutely. Just basically any single act of violence, okay? When we think about chronic trauma, we're talking about repeated or prolonged exposure. So now in our worlds, we're probably thinking more along like a domestic violence or intimate partner situation that's ongoing, community violence, maybe living with a long-term illness, or some of our more social determinants of health kind of issues, like living in poverty can be a chronic trauma. Living unhoused could be chronic trauma. Living with undocumented status. Sure, living with someone dealing with substance abuse. Absolutely, thanks for that. So that's chronic. Complex takes us sort of a step further. It can be a little hard to untangle the chronic and the complex, but a couple things that make complex trauma stand out. It's typically in an interpersonal context, and typically includes exposure to multiple traumatic events. Okay, so one thing that comes up there a lot is human trafficking, right? Multiple traumas. A lot of times trauma that occurs within a caregiving system, or ongoing abuse or neglect by caregivers. It's typically severe and repetitive, often in childhood, though not always. And it's also often associated with feelings of hopelessness, kind of the sense of there's no end in sight for this trauma and what's occurring, okay? And then talk to me about historical trauma. Someone throw me some really good examples there. Boarding schools. Yeah, thank you. Historical trauma, as it says on the slide, we're looking at things that are cumulative, carried across generations. So we often talk about epigenetics there, right? And systematic oppression of peoples. Does anyone have another example for me of some historical trauma that we can think about? Yeah, Indigenous oppression. Yep, on Native people. Genocide, slavery, right? Forced relocation. And as we touched on a little bit already, and if you have ideas, please feel free to keep sharing them. Some of these things fall into multiple categories, right? Like racism and religious persecution or sexual and gender discrimination could have an acute incident, could be contributing to complex trauma or chronic trauma, and certainly fits this historical multi-generational model. Okay, abuse by priests, great example. Okay, so what's another example of trauma that everyone is experiencing right now that we have not covered? Yes, COVID, thank you, thank you. The pandemic, we are all living through a universal trauma right now, absolutely. So yes, there's so much good stuff happening in the chat right now. Civil unrest, forced isolation. There's a term that I didn't include in this PowerPoint called a syndemic, okay, which basically means the co-occurrence of multiple epidemics, right? We are living through COVID, we are living through an epidemic of racism, an epidemic of the opioid crisis, right? All of this is sitting with us, causing trauma for everyone that we engage with. So that, I think, is a really big deal. Same storm, different boats. Thanks, Terry. Absolutely, right? And again, we have that, what's that personal experience of trauma perspective. So we can really view all this through the COVID lens. Now, in the same context, again, we are typically thinking about acute trauma, the sexual assault that caused our patient to present to us, right? That's often, we know, in the context of child abuse or elder abuse or intimate partner violence as well, right? So a little more complicated than just that acute abuse, although it can be a single incident, obviously. And I think that when people think about trauma, these are some of the first things they think about: sexual assault, domestic violence, that tends to come up, right? And certainly if we are looking to prove widespread impact and why people should care, that's enough. It's frequent enough, right? You all know these statistics as well as I do. 1 in 3 women, 1 in 4 men are victims of some sort of physical violence by an intimate partner in their lifetimes. 1 in 6 women, 1 in 33 men have been sexually assaulted, right? We're not really getting into ACEs today, right? But we know that 12.5% of people have 4 or more ACEs, right? This is common. Trauma is common, right? We can prove that people should care just from that. But in truth, as we've discussed now, examples of trauma are infinite, right? And our patients are bringing into the room far more than the acute trauma that caused them to seek care, all right? So that's a little bit of a foundation for us to build off. Now, when we talk about the effects, again, you all are the experts here, so my apologies if it's repetitive to what you know. We know that trauma has lasting effects on an individual's functioning and well-being. Neurobiology of trauma, right? We know that trauma impacts the way our brains function. It impacts our immune response. It impacts our health risk behaviors. It impacts chronic diseases. It impacts neurodevelopment. We know, as comes up for us often, that trauma impacts our abilities to perceive and interpret information, and certainly alters the way that memory is processed, right? Which is salient for us when we're looking at our history of the assault, right? Things that may seem to an outside and untrained eye, like they're characteristic of someone being dishonest, right? We know actually makes really good sense with the way that the brain processes trauma, right? We know that trauma invokes that fight, flight, or freeze response. And some people go ahead and add fawn to that as a 4th F, fawn meaning sort of subjugate your own needs for the well-being of others. All of these are ways to seek safety, right? These are all protective. But we know that when we put this in the context of chronic or complex trauma, the protective responses of adrenaline, of cortisol, of that acute stress become toxic, right? And they alter our prefrontal cortex. I think we talk about this most when we're talking about ACEs, adverse childhood experiences. We know this. You hear the anecdote of like, these are the hormonal and physiologic responses that we need to have when the bear is chasing us, but when the bear is in our house, and so those effects are happening all the time when we're just living our lives, our bodies aren't built to withstand that stress, right? We also know that trauma alters belief systems. It changes our worldview, okay? And that can be our worldview both about self and other across multiple domains that include safety, self-esteem, and esteem of others, intimacy, control, and trust. These are the domains found on the trauma and attachment belief scale, sort of where that concept comes from. We know that it impacts shame and stigma and decreased hope and optimism when viewing life outcomes, right? And forward thinking. I have a star by trust because I think that's really important for us in the SANE context, right? Because that includes trust in the healthcare system, okay? Trust in systems in general, but for us, saliently, healthcare system. It also can create difficulty or barriers to creating a therapeutic and trusting relationship with a caregiver, okay? And then just more globally for people, dysfunction in creating meaningful connections and relationship, right? So as far as coping mechanisms, we know that these are personalized ways and strategies that allow folks to function in their daily lives, right? In the face of trauma, whether that's present and ongoing or past trauma, okay? That's sort of a working definition of a coping mechanism. And we also know that they can appear dysfunctional and maladaptive, right? There are a lot of coping mechanisms that we wouldn't wish for ourselves, for our patients, for our loved ones, right? But in the end, they either do or at least are framed to facilitate survival. And I want to lift up and honor that some of that language comes from Stephanie Tillman, who is a real expert in trauma-informed care. And I'm borrowing a little bit of her language here. You'll see her heavily in the citations and references at the end as well. So a couple of the coping mechanisms that I think are especially important to lift up in our SANE context, self-medicating, right? Sometimes that plays into circumstances leading up to the assault that we may be seeing them for. It also may be part of the plan for coping with the aftermath of the assault or our healthcare, right? And that ends up mattering. We talked about this a little last time I was with you, because it can have impact on some of the medications that we can provide and things like that, right? Also, kind of we see not infrequently folks who have a history of sexual violence sort of reclaiming their sexuality in ways that aren't always the healthiest, or that at least put them at risk of negative health outcomes. So, so just a couple of things to keep in mind. Unexpected behavior. So people who have experienced trauma can have difficulty regulating behavior, or sort of a lowered threshold for regulating behavior and controlling expression of emotions. So we can see that in anger and aggression. We also, a couple of additional coping mechanisms, right? We can see self-harm and dissociation, right? And those will come up again as we continue talking. So I want to make sure I name them now. Unpredictable and unexpected responses to sort of commonplace events, right? So we need to keep that in mind during our time with patients, that scripts and norms may be kind of out the window, right? With folks who have experienced trauma. And then finally, health sequelae really is its own talk, right? And we've touched on some of that already. So I'll just sort of throw the bullet point at you and continue on our way. I'm not seeing any questions come up, but please feel free again to throw them out there. So we have to talk briefly about activators. You may have heard this referred to as triggers, and there's sort of a movement to move away from the word triggers, because that really is the language of weapons, right? A trigger is to fire a weapon, right? Whereas to activate is to induce increased activity or encourage development, right? But to try and, again, sort of move away from a language of violence. And also, I think it's just sort of becoming a little bit of a stigmatized word or overplayed word. So many people are shifting to activators. So this is something that reminds someone of or initiates a flashback to a prior trauma. It can occur at a conscious or subconscious level, and things can be activated by all five senses. Smell is actually a really powerful window into memory. Sound, feeling, taste, right? All five senses can sort of cause someone to experience these sort of flashbacks or activation that can result in extreme distress that is really similar to what was felt at the time of the initial trauma, that therefore may be really disproportionate to whatever's going on right in that moment, right? We sometimes see physical reactions that mimic a reaction to the initial trauma. So sometimes people will experience vomiting, right? Or things like that when someone's feeling activated. Now, we know that trauma is very personalized, and activators also are very personalized. And one of the things that this means is that we can't predict what it will be, right? And sometimes patients can't predict either. So we always need to be aware and thinking about that. We don't know what's going to cause someone to become activated and experience a flashback, dissociation, panic, or anxiety. All right. That's sort of where we'll leave our more generalized trauma talk and move on a little bit to conceptualizing trauma-informed care. Okay, I'm trying to be mindful of the time. We've got less time today than we did the last time I was with you. So hopefully we'll make it through with flying colors and time for some discussion at the end. So again, we'll use the SAMHSA definition of a trauma-informed approach, which is one that realizes the widespread impact of trauma and understands potential paths to recovery. It also recognizes the signs and symptoms of trauma in clients, families, staff, and others involved in the system. And so you'll notice this focuses not only on the individual level, but also on sort of an organizational level, although today we'll be focusing more on that individual level when we think about our patients. It is also one that responds by fully integrating knowledge about trauma. And then finally, and one of the things that's so important for us, it seeks to actively resist re-traumatization. So this will guide the tone and process of our care. All right. So you'll notice that definition is the highlighted and underlined words. You've got these 4 R's. Okay. And so those are really the key assumptions of a trauma-informed approach. Okay. SAMHSA also offers these 6 key principles of a trauma-informed approach. But today we're kind of going to gloss over that and leaving that there just for your information. They also are a little bit more focused at that organizational level. And while we can break them down into a sort of more of a patient care examples and operationalize them that way. For today, we're kind of going to leave that and we're really going to focus on those 4 R's. If anyone has questions, again, toss them at me. Okay, so that's very pretty and academic and all the things, but what does this really mean and how do I apply it? The first and sort of most important concept is it mandates a paradigm shift. So when you're working with someone who is having a reaction that feels disproportionate, when you're working with, a lot of times these are the difficult patients, right? Things like that. It causes us to shift from saying, what is wrong with you to what happened to you. Okay. And that shift in mindset, that paradigm shift, opens space for a trauma-informed approach. Okay. The next key thing is to use to think about applying this universally and as the standard of care. Okay. So we think about standard precautions in healthcare all the time, right? I don't wait for someone's hepatitis test to come back positive to use standard precautions when I'm dealing with blood in a healthcare setting, right? Or like in life, if I'm able to and lucky enough to have gloves around, right? So it's the same idea when we think about how we're going to apply a trauma-informed approach. So a universal precautions approach is one in which we are expecting trauma to be present. And that makes sense when we've talked about how common trauma is, right? And how many things can create this traumatic response. It is just intuitive to do so. So a lot of times people will talk about a trauma-informed approach with a couple of like key populations. They're like, oh, well, that makes sense in X, Y, or Z context. And one of the things that I would push you to think about if you haven't already, or to use this language when you're talking to other colleagues, is around making this a standard of care. Because chances are that each person you're dealing with has experienced trauma. And I think we've all agreed after living through COVID, we all are there, right? So what are some special populations where it might be more intuitive to use a trauma-informed approach? Where are some places that like everyone's like, yeah, that makes sense? I got quiet in the chat. Yeah, SANE exams. Thank you, right? And I'll hear not only from SANE providers, but from like primary care providers or OB/GYNs, people talking about, well, yeah, if I know that someone has a history of sexual assault, I will approach that exam differently. If we know our patients are not obligated to disclose to us, right? And often don't, right? So again, beyond that, other places that I think it's a little more intuitive for people, I hear it a lot with first pelvic exams, that people approach a first pelvic exam really differently. And I also sometimes hear it with the LGBTQ community, that because there's sort of an awareness of some historical medical trauma and distrust, and or because sexual practices may vary, that sometimes there's a different approach there. But really, every human deserves this approach, okay? And I just sort of spoiler alerted myself, everyone means everyone, not just patients, right? This is something that we can turn towards our colleagues and coworkers, towards our friends and families, our whole communities, again, especially in the aftermath and ongoing COVID crisis, but really just with a generalized understanding of trauma. And finally, this also is something that we can turn to ourselves and look at ourselves with a lot of compassion, and our SANE and forensic nursing teammates with a lot of compassion. I told you I wanted to talk about vicarious trauma, so here we go. Vicarious trauma is those changes in worldview that occur based on repeated exposure and empathic engagement with others' narratives of trauma. And if that doesn't define working as a SANE, I don't know what does, right? My doctoral research looked at a group of SANE nurses and a group of what I called happy nurses. So I looked at postpartum and obstetric nurses, eliminated NICU, right? And asked those folks if they themselves had a history of sexual trauma or not. So we had kind of SANE, non-SANE, trauma, non-trauma. And what we found was that the SANE nurses with no personal history scored as high on levels of changes in cognition related to trauma as non-SANEs who did themselves have a history of sexual trauma. Okay, so this is real lived experience for all of us. And if you recall, I said that the DSM-5 had sort of narrowed their definition of trauma. They left in something that talked about the repeated or extreme exposure to details of traumatic events, which specifically applies to workers who encounter consequences of traumatic events as part of their professional responsibilities. That is us, okay? So we all deserve this approach to each other, to ourselves, to our loved ones, okay? We'll move on to pelvic care specifically. And I'll pause. I know that that can be a lot to sort of take in if anyone wants to throw anything up for a question or discussion now. Okay. So when we think about the pelvic exam, what are we talking about? We are talking about no one's favorite activity, right? The pelvic exam is by definition, it puts the patient in a vulnerable physical position. They are laying down, they're on their back, and I hate calling them stirrups, but they're in footrests or stirrups, right? This is a sort of a limited mobility, vulnerable position by its nature, okay? And then you add to that getting undressed, okay? Taking off your own clothing, which may feel protective, which may feel warm, which may feel like home or the one thing that you have that's keeping you grounded, right? Our gowns and paper sheets are horrid, right? Now you may be under crunchy paper and sticking to something and all kinds of things, right? And this is in the best of circumstances, right? And then we add to that your genitals are exposed, right? And beyond that, your genitals are exposed to a stranger because it turns out that a clinician is a stranger, right? So there's a lot of stuff going into a pelvic exam that is not awesome in the first place, okay? And then we also have to go deeper with the thoughts about the clinician, that there are inherent power dynamics between a patient and a provider, right? There's a knowledge gap, there is a role gap. Point blank, the clinician is, oh, and I just said to get away from language of violence. So without a doubt, the clinician is in a position of power, okay? We also have to deal with the fact that there may be feelings of sort of medical necessity in going through this, rather than having the opportunity or option to decline services, that even if we're doing a good job of giving someone the opportunity to decline, they kind of can't if they want the service, right? Like you could actively not want a pelvic exam and know that, hey, if I want this IUD placed, if I want this testing done, if I want this itch assessed and to get my yeast infection treated, if I want this forensic exam, I have to go through this, even if it's not something I really want, right? So there's all kinds of power issues going on there. And then finally, there's the exam itself, right? We haven't even gotten to the actual exam, but this comes with the potential for some discomfort and possibly pain. Although we do the most gentle and exceptional pelvic exams that we possibly can, it's not comfortable typically, right? Although it shouldn't hurt, it's not typically comfortable. Just the sensation of pressure and a stranger staring at your bottom is not comfortable, right? And then we add to that the context of the SANE exam. This is now the most thorough genital exam that people have ever experienced. Typically, it takes a long time. There's often shame. There's often fear. And And then, gosh, we add genital photography to the mix, right? So there's a lot of discomfort here. A quick note also about language, and we'll talk language at a couple points in the presentation. One of the things that we often say, or that I often hear said during these exams is, okay, I'm just going to check for injury. And I want to invite us to think about what that sounds like to someone that doesn't understand what's going on, right? To us, that's what's going on, right? But when you think of injury, I think we think of like gaping wounds, right? Injury sounds scary. Injury sounds like broken bone. Injury sounds like long-term healing. So, well, that may be what we're doing. One of the things I used to do a lot is to talk about when we say we're assessing for injury, think about it the way that you think about like oral mucosa, right? I've used different language with patients, but you bite your cheek. It hurts terribly. If you look at it, you can see where you bit your cheek, right? But it heals really quickly, and it heals without lasting impact. Now, of course, that's not always true, right? There are circumstances where this is not a spiel you can give, where there is true gross injury that's occurred. But again, I just invite you to think that when we're looking for a small abrasion or a bruise or redness, things like that, that's not necessarily what patients are hearing when we tell them what we're looking for on this exam. So I think that's kind of a nice way to frame it that people can understand. Bottom line here, we cannot ignore the intimacy of the work that we do. And it's uncomfortable for me to use the word intimacy when we talk about our work, right? Because it's professional, and intimacy makes people feel like we're talking about sex and things like that. And it's not a comfortable connection, but we can't deny that these are people's private and intimate body parts, and that penetration of the body is intimate, right? And so while this is normal for us and medical and sterile for us, it is anything but normal for our patients. And that's really important context. I also noticed as I was prepping this, that I talk a lot about, well, and it's because it's a pelvic exam, so I suppose this makes sense, but I'll apologize that I'm not really at all talking about an exam on folks with penises right now. So, and someone asked in the chat, what do I say instead of looking for injury? Often I will say looking for injury, but then I'll qualify it with that sort of talk about, and I know that can sound scary. Let me explain what we're talking about, and then give more of my spiel about, when you bite your cheek, right? So it's still maybe the language that I use, but I'll just try to make sure that I bring them into my circle and into my thought process, and help that all make sense. Does that make sense? She says to the empty screen of no one responding. Yes, hopefully that makes sense. Thank you. All right. Okay, so what are some activators that might be common in a pelvic exam? What are some things that might be activating for people? And I'll wait for people to put some ideas in the chat here. These could be verbal, these could be physical. What are we thinking about? Positioning. Yes, absolutely. So laying on your back with someone standing above you could absolutely be activating for someone, right? Yes, thanks, Jill. Quickly grabbing or touching the leg or other body part, being touched, absolutely. And let's take that even a step further. We hear not infrequently about people who sort of help someone's legs open or push someone's legs open. Yes, thank you. Mary just said it. Pressuring the inside of legs or thighs. So that's something we should never be doing. Think about your language, right? A couple of the language things that we hear that sort of mimic things that we can hear in assaultive or sexual situations are things like just relax or open your legs wide, right? Things like that. So how can we language this differently? Can be things like, often I'll use the cue of my hands. So if someone has their knees too close together, I'll put my knees out my hands out where I want their knees to fall. And I will ask them to allow their knees to meet my hands, right? So they're in control, and I'm showing them how open I need their knees to get, right? But I'm certainly not pushing them out. So that's one way to do it. I'll also sometimes say, like, let your knees fall open as if you're trying to like you're doing yoga, or trying to make your knees touch the walls. Okay. What else? Instead of just relax, let's talk about, sometimes depending on the patient, this sometimes is not language I'd use, but I'll sometimes say, breathe into your butt. And if that makes them laugh, all the better, because we know that laughter helps relax the pelvic floor, right? What else? Talk about just dropping the muscles in your butt down to meet the floor or down to meet the table. Okay. So lots of different ways that we can do this. A couple other thoughts that have come in the chat, the quietness of the room, allowing for unwanted thoughts, absolutely could be activating. And then just, yeah, prior history of sexual assault or childhood sexual abuse coming up for folks. Another one could be just feeling rushed into a decision, could be activating for someone. So the next question is, what does trauma look like? Okay. And we've got in there already, someone put closing their eyes during the exam, okay, which I think was put in there around an activator. But I would say this can be a really interesting, what does trauma look like? That's one we can't tell, right? Someone could be closing or covering their eyes because they're in an activated space, or they could be closing their eyes because that's how they get relaxed and they're actually managing really well, right? And we're not going to know, okay? Sort of the most obvious that we hear about a lot is someone who like kind of jumps up the table, right? I hear that a lot when I'm talking to sort of OBGYN kind of folks and nurse practitioners who, you know, we've all experienced that patient where we didn't know they had a history and then they're up the table. And that sometimes is a good clue that perhaps there's a history that we don't know about. Crying, right? Except our patients are often crying throughout our whole or large portions of our time together, right? Could be rapid breathing, could be breath holding, could be, yes, fists clenched, thanks, Jill, shaking, trembling, other tightened muscles, right? Could be fists, could be closing their legs, could be just tense pelvic muscles, right? Our bodies are really smart and protective, right? So if we don't want something to happen, it's normal for our muscles to clench down. Another thing that's interesting is that it can actually also look like calm and peace, when in fact what's happening is that they're dissociating. And so one of the things that's such a challenge is that we may not know, right? Even if we ask, we may never know if someone is activated, but we can do our best to be aware and to have the conversations and to move through, again, with this lens of looking for these things and trying to respond appropriately. So, and again, I want to acknowledge a lot of that list came from Stephanie Tillman. So, okay. When we move to sort of a SANE specific context. So one thing that's important to keep in mind is there is some literature that suggests that seeking healthcare immediately after a trauma gives us a really, really important opportunity to focus on that resisting re-traumatization, because when it's linked, and this can be sexual assault, or this could be like getting medical care after a car accident, that the lines blur between the trauma and the healthcare experience, right? So the participants' memories of the traumatic event kind of all move together. So the more, the better that we do our job and give this care, the more we can minimize that like traumatic association with healthcare and help our patients continue to seek healthcare through their lifespan. So another opportunity to talk about a paradigm shift. This is really, really important to me. I expect that you all have heard people say that in a forensic exam, the body is a crime scene. Okay, this is one of my least favorite things to hear when we're talking about SANEs. We talk about this exam as if it's re-traumatizing and it's such a, you know, all these things. And that is not to say that it can't be, okay? And I don't get to own for someone what's traumatic and what isn't, right? However, if we can shift our thinking about this exam to something that, from something that is traumatizing to instead something that is healing, that we are going to help them begin the process of healing, that is incredibly powerful. Okay. So as much as you are able to make that shift for yourselves, for your colleagues, and especially for those of you who like work in an ER and work with folks that aren't SANEs, I think, or wherever out in your life, telling your family and friends, when we hear that narrative of how bad the SANE exam is, we've got to start to shift that. Okay. So key elements to trauma-informed SANE care would include anticipatory guidance. Okay, so we need to be telling these patients what's happening before it's happening. No surprises. Okay, we need to be prepared for that range of responses. We've already talked about that a little bit, and that can mean managing anger, managing dissociation, managing difficulty with making decisions. Right, someone who's been in an ongoing DV or IPV relationship may not have any practice making decisions because all their power and control has historically and systemically been taken away from them. Right, shared decision making. Giving patients as much control and choice and power as is possible in the healthcare environment is key, right? And again, you all are the experts in that, but that's so important. You know, I feel like I intended to say this at a different point. Another thing that we have to keep in mind is that healthcare historically isn't safe for a lot of patients and a lot of populations, right? So that's another thing that they're bringing in potentially to us to keep in this frame, okay? And then of course, informed consent. And we are now gonna do a nice deep dive into informed consent. So here we go. What is consent? Throw some stuff up in there for me. What is consent? Y'all are teaching about this all the time. Throw me something of what consent is. Permission, yes. What has to go with it? Yes, okay. Fully understanding options, informed decision, verbal, yes. There's so many things that go in here. You can keep tossing stuff up, but I'll share my list because I'm scared we're gonna run out of time. So consent is unmistakable, often verbal, an affirmative yes, I love that, Lynn, thank you. It is uncoerced and freely given. It is reversible. Deciding that you consent to something at one point does not mean you can't decide that it needs to stop. It is specific to the activity that's going on and does not imply a blanket consent moving forward. And it is informed, and you all were so good at putting that up there. Big take-home message. Also, the absence of a no is not a yes, okay? So a definition here, or excuse me, not a definition, a quote that I think is really important, again, comes out of a brilliant article by Stephanie Tillman. Consent is a clear dialogue between individuals to engage in a specific activity. Expectations for consent to intimate examinations in healthcare should be equal to, if not exceed, expectations for intimate interactions in society. In healthcare settings, actions that would be considered coercion or assault in social settings are often erroneously labeled as clinically or medical legally rational. That is incredibly powerful. Okay, so we'll sit with that for a minute. An exam without consent is assault. Okay, and something can be perceived as assault if a patient doesn't believe that they have given consent freely. So unintentional misunderstandings can happen for a million reasons, right? Again, that goes back to that concept of what's routine for us is anything but for them. Also, people are presenting to us with kind of that trauma brain on, right? Where things are not firing in sort of a typical way. People are also coming to us with major biological needs and deficits, right? If someone is assaulted at a party at 1 in the morning and they don't make it to your ER until 3 in the morning, and they have not slept and they have not eaten, and also now they're worried about who's going to be at home at 7 a.m. when the kids wake up because SANE exams take a long time, right? Or who's letting the dog out, or how they're going to tell their employer that they can't make it to work the next day because of what's going on or whatever it is, right? There's 1,000 reasons that misunderstandings can occur, okay? So all the more reason that really explicit ongoing consent process is so important. Context. So we've talked about that it may not just be the unique trauma, but there may be a trauma history. Again, that historical violence or mistrust in the medical system. Okay, so again, especially for some of our more vulnerable populations, people who are dealing with classism, racism, and the historical misogyny of the healthcare system. Okay, coercion. This is an incredibly important discussion. Quickly, so often, so directed counseling, right? This can look like, I would prefer X, Y, or Z because in my experience, such and so, okay? Or what I would want for my loved one is, right? And well, that may be really well-intentioned. And sometimes patients are overtly asking for it. And there's some reality to, they are coming to see you because of your expertise, right? But the issue is that if they then choose something different, there can be fear of letting you down, okay? Or that you may judge them or whatever else, right? So sometimes some of those sort of directed counseling techniques that may not feel coercive can be problematic. Then of course there's more overt coercion, and that would be things that look like more generally, okay, I hear that you'd like to decline this, but what I want to emphasize is blah, 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 blah. Okay. Or in our specific context, okay, like we cannot do that, but law enforcement's not going to be happy, right? Or that's not really great for law enforcement or whatever it is. Okay. That's fairly overt coercion. And then, of course, there are also examples that can truly be defined as assault, right? And sort of the best example of that, I think, is something that is when we'll hear a provider say something like, just another second after being asked to stop. So I bring us back to that quote from the previous slide, that in healthcare settings, actions that would be considered coercion or assault in social settings can be erroneously labeled as clinically or medical legally rational. So that, is we're so close to getting this photo, this swab, this pap smear in a non-SANE setting, right? They've come so far. We've got the speculum inserted. They didn't want that anyway, and they did such a great job with that. So I'm just going to obtain the sample for them. Consent is reversible, and in a sexual setting, none of us would stop at saying, okay, so someone consented and then they said no in the middle. Imagine if someone said, if someone's consensual sexual partner said, just another second, I'm really close to finishing. That is assault, right? And yet I think we rationalize that in healthcare sometimes. So we need to really grab a hold of that and reconceptualize that. One strategy that I like to use is to talk with patients about saying pause versus stop, or pause versus out, or pause versus done. And you can come up with the language that's in your vernacular that works for your patient. But set that up before and say, so here's the deal. As we're moving through this exam, you get to call the shots, and you stop at any time. You can say stop at any time. If what you need is a minute to gather yourself, or to ask a question, or for things to slow down, or you're just starting to activate or starting to heighten and you just need a minute, say pause and I will stop what I'm doing until you tell me that I'm able to go on, or we decide to stop, right? On the other side, if you say out or stop or whatever word you choose, I will withdraw the speculum or whatever else is going on immediately. And it's important to me that you know that, because that may mean that we don't collect a swab, right? That ultimately would be beneficial, or that ultimately is something you've stated that you desired, right? But most important to me is your bodily autonomy, right? And your right to consent to what is happening to you and to your body. So if you say stop or whatever word we use, I think sometimes people like out because that's weird, right? That's like different, where stop might just come out of someone's mouth, and then you can say, do you mean pause or do you mean out, right? And then they can tell you. But you set them up front that if you say this word, it's sort of like, if anyone's familiar with like BDSM safe words, right? If you say your safe word, like this stops. And then they know that that's something that's happening, right? So it's not like they're like, oh, I wish you had just kept going, right? Because you've set up this expectation. Oh my gosh, and Susie, we're at an hour. Can I keep going? I have this slide and one more slide. Are people okay? If people have to get off, I understand. Let me frame it that way.
I think you're fine to keep going.
Okay. Awesome. Yeah. We're very close for your patience and tolerance. So, okay. And now I've lost my train of thought. So anyway, so that's a strategy that I like a lot, is that sort of two-worded phrase. Again, just really important to understand that a true informed consent process allows for both a yes and a no. Right? Just like the absence of a no is not a yes in a like social encounter, we need to allow for a yes or no at every stage. And I think it's very easy for us not to, because they came to us for a service, right? So we're like, they're sort of by being here, they're consenting. Nope, they get to say yes or no at every phase. They have the right to informed refusal. Okay, and that's true even if your crime lab or law enforcement or prosecutor doesn't like it, right? What else? Again, there's an inescapable power dynamic. Also, thanks, Jamie. Thanks so much. Also, remembering that a full range of risks and benefits should be explained prior to seeking consent, because if we're explaining the risks to declining only after they've declined, that can be coercive. Okay. Finally, a note about language. Think about the way that you talk about your patients. Okay. The difference in perception between the patient declines or decides against and the patient refuses, and what those implications are. Okay. And then lastly, strategies for care. Step one, we're going to explain the steps and equipment before each step. And that means not only what to expect, but also the rationale. Why are we doing this? Again, that contributes to, like, if you choose to not do this, what are you giving up, or what are you gaining, right, by choosing to do it or by not doing it? And again, the risks, benefits, and alternatives. And what you'll see is that really resembles informed consent, right? So that's sort of bound in. Thinking about positioning. So this is, how do you utilize the room that you're in? Are there different parts of your SANE process that can be done in more comfortable places, right? Can someone be fully clothed to give their history? Can someone be in a separate room where they're not staring at medical equipment or at a, like ER gurney bed, right? Like, what can we do to make things more comfortable? Also positioning as far as, does someone want eye contact with you or not? If you have a table that can be adjusted in that way, right? How about clothing? When do they need to take their clothing off versus when can they be covered and in their own clothing, and so on. So chaperone, you'll notice I have a question mark. There's a newish recommendation from ACOG that a chaperone be present for all genital and breast exams. So a chaperone is not just an extra person in the room. They are a medical person with training in privacy, in best practices, and in misconduct and reporting. So this is clearly different than an advocate or family or friend. Now, in the same context, of course, there are barriers to this, right? Barriers including evidentiary, right? That fewer people in the room is better, so less people are breathing and selling on your samples, right? That's real. Similarly with the medical legal, or the hearsay exception, right? The more people in the room, like, what does that mean, right? These are things that have to be explored, and I don't have the answers to them. Also rapport, because they're not going to be present through the whole process. So bringing someone in just for the genital exam is going to be a little odd, potentially in the same context. However, as this recommendation has come out, it is something definitely to keep in mind as practice standards evolve. And we've got someone saying they always offer a chaperone, so that's awesome. Maybe Carrie can share more about what that looks like in their health system. So this is definitely something to consider, and I think we're going to be seeing more and more of it. And there are some real benefits. Okay, so we're going to focus on empowerment and reassurance whenever you can. Okay, so again, this can go back to our oral tissue example. And reassuring our patients, if it's true, that things look healthy and normal, right? Remembering that some folks have never had an exam before, have never had a provider tell them that their genitalia looks normal, okay? And that in and of itself can be incredibly empowering. Often I think people think that they are broken by an assault, or that partners or the world will be able to tell forever that an assault has happened to them, and to tell them, hey, look, everything looks really healthy and normal, can be incredibly healing and powerful. Going along with that, consider offering your patients a mirror, or if you have the capability, to let them see the photos that you're taking. Some folks will have a screen that they can actually be projected on, or just to see the back of your camera when you're done. Of course, they also have the option to decline that. That may be really unappealing to folks, but to give someone that choice can be really, really empowering. Promoting comfort, in addition to things like clothing and positioning that we've already talked about. I would think about an appropriately sized speculum. If you only have one size of speculum, you need to reevaluate that. Draping for modesty and comfort, and remembering that that is something, and again, like the viewing a mirror or photos can go either way. This wasn't in a SANE context, but I had a very early, when I was a nurse practitioner student, I had someone who is a dancer for a living who was in, and she did not care at all about having that sheet over her. And I kept offering it to her because I was kind of uncomfortable, and it just seemed like what I was supposed to do and what I was taught to do, but she didn't care at all. And I had a preceptor observing that exam, and she really lifted that up for me afterwards. So that was my own stuff that I was bringing in, right? However, often modesty and coverage is going to help people feel more comfortable. So making sure that you're being aware of that at every phase. And then a last thing that we've got to talk about here is lubricant. Okay. Discuss this with your crime lab if there are concerns. At a minimum, use water on that speculum, but a water-based lubricant should be okay. You'll document what was used. But again, we need to focus on promoting the patient's well-being and comfort, okay? And then finally, communication preferences. And I mentioned that because I've spent all this time talking about explaining every step and all these things, and all of the communication that needs to happen for a true informed consent process. But it is also true that there may be patients who say, look, I get it. You've explained what you're going to do, and I don't want you to say what's happening. I don't want to hear this is where you're touching, or this is what you're doing, or this is right. Like, give me the bare bones. And then I don't want you to keep talking about this, either because I want to put headphones on and go inside and like manage my own stuff, or because I want to talk about the weather or have a conversation with the advocate, if you're lucky enough to have an advocate present, about my pets or whatever it is, and just really disconnect. And that's okay too, right? So you really need to, again, like decenter your own desires and communication style preferences, and respond to theirs. So that was really fast moving through all that, a whole bunch of references. Are there any questions? And I will leave, as we pause for questions, I'll leave my contact information up. I'm very happy to talk about any of this or assist in any way if I can. So Carrie's talking here. This is what you do with the chaperone. She'll ask if they want another nurse or EMT to support them, not to help you during this part of the exam. Is that right? And that most will decline, but it's always offered. Yeah. That's great. Okay. Yes, there's somewhere to watch later. Although Susie will give you better information than I will about that.
Yeah, they should be posted on the SANE website in about 2 weeks or so. The other 2 webinars are already there. There's a tab now called resources that they're just sitting there. So you should be able to see the first 2. And if you have questions, you can also raise your hand and I can unmute you guys too, if you don't want to type.
There's also a thank you slide, but I'll put it back on my contact information. Well, thank you guys for spending this time with me. I really appreciate it. Thank you for the work that you do. Again, if I can support in any way, don't hesitate to be in touch.
Thanks, everyone. And I threw in the chat also a link for our evaluation. So you can click on that and open it. It'll also come through in an email. So if you don't open it now, you should be able to get it later. But feedback is definitely appreciated. This helps us target education and needs and things like that. So please do give us your feedback. And with that, we'll let you guys go. Thank you for attending.